Welcome to Coffee with Kyle number 17. I'm Kyle Ridgway. Good evening. And as has been a trend over the past week, this happens to be another beer with Ridge in the evening time. So I'll give you folks out there a little taste of what I'm drinking this evening. This is a Hop Road Imperial IPA from Roaring Fork Beer Company in Carbondale, Colorado. Great beer. Of course, I'm a fan because of the purple can. So let's get right into it. So today what I wanted to talk about a little bit was actually theory versus experiment, or the theoretical versus the experimental. And kind of disclaimer right up front, I am not a philosophical or research expert in this topic. It is something that is very interesting to me, but I cannot claim to be an expert in the background history of research differences between theoretical and experimental approaches to understanding the world. This is something that if you delve into the physics and philosophy literature, you will find much more than you want to know about it. But it's something that, at least for me, I've thought about at least a little bit over the past 5 years or so, especially after reading some older writings by some very deep-thinking physical therapists, and really actually reading outside the realm of physical therapy and delving into the world of physics and philosophy. This is talked about a lot more. So I'll give you my very 30,000-foot view, single millimeter deep understanding here. Physics, I think, is the best example because it's so mathematized. It makes it easier to kind of understand and parse. But essentially, if you have a theoretical person, a theoretical physicist, a theoretical researcher, or a theorist rather, they are going to construct theory, which in the physics world means they're likely going to come up with equations that they hope will predict real-world events. Now, this theory doesn't happen in a vacuum, right? So what we already know about the world, other equations, other theories, will obviously feed in to the theory that any theorist makes. Well, the main thing that theory does is make a prediction. But of course, even if the theory makes sense, even if the prediction seems reasonable, even if the philosophical tenets of it make sense and the premises seem to equal the conclusions, we need to vet or test that theory in the real world by running actual experiments to see if the theory holds true. So in physics, there's this obvious back and forth between theory and experiment, and each of them feed into each other. So if you're a theorist and you make a theory and you have an equation which you think predicts some certain outcome or should predict some narrow or broad phenomenon, an experimentalist runs an actual good experiment and it doesn't add up, well, your theory has just been potentially disproven or has a little less support for it. Therefore, you need, as a theorist, to take in the experimentalist results to tweak your theory, and as an experimentalist, you need to understand the theories that have been proposed. And so one of the questions that I've thought about in physical therapy specifically, but I would say healthcare generally, is do we lack true foundational pure theorists in physical therapy and healthcare? And my sense is that there's no true straight theorists for a couple of reasons. We don't use the label, and I think maybe we should. The second is we are so focused on empiricism, which is not bad. We were focused on what works, maybe why it works, and getting outcomes. And that makes sense because as clinicians are appliers. Clinicians are where the rubber meets the road of applying knowledge, and therefore they're craftsmen really, and they are applicators of knowledge. And therefore it makes sense that in fields such that are clinically oriented, such as physical therapy and medicine, that it would be a space that's essentially devoid of true theorists. Now, that being said, I would postulate that we all theorize or attempt to create a cohesive narrative, a theory, all the time. Now, we do this clinically, but as researchers naturally must theorize even if they're not truly theorists, right? They have to come up with predictions or ideas about what they think may actually occur and design studies to answer those questions. So I would argue that as a clinical researcher, by purely proposing a experiment, you're delving into theory because you've already potentially made a prediction. Even though obviously in a well-designed study, what the prediction is always that the null hypothesis is true, at a deeper level, we are doing some philosophizing and some theorizing about what works and what it might work and the best design to see if something would work. Now, what I would say is that especially historically and especially in physical therapy, kind of some of the pioneers of our field really had to be accidental theorists. And the reason is that the empirical arm or the empiricism or the experimental arm of physical therapy wasn't very well developed. So these clinicians had to rely more on kind of basic first order or first principles thinking on potential mechanisms and trying to understand what they were treating. But then they had to theorize and utilize personal empiricism or really personal experience to develop, test, or refine theory. And I think the history and development of manual therapy within the field of physical therapy is an interesting landscape to traverse to kind of see this in action. Now, one of the greats in our field that has really influenced my thinking in this regard is actually Jules Rothstein. And he was the editor of PTJ and worked at Wash U in St. Louis and did a bunch of things research-wise, clinically, and really debate and discourse-wise in the field of physical therapy that I will link to in the comments because I think there's a lot of great reads there. But he kind of tuned my lens that we're kind of obsessed with what works and what to do. And I want to read in full an editorial that Jules wrote back in the day, and it's called When Thoughtfulness Dies. In this era of managed care and outcomes-based practice, the battle for reimbursement and professional survival looks more like a war every day. And as with any war, there are casualties. The first casualty of war is said to be truth. But in this war, the first casualty seems to be thoughtfulness. Combatants appear to be lobbing outcome studies at one another like grenades. Just when a direct hit seems imminent, the explosive impact is diffused by accusations of irrelevance or even more damning, evidence of poor methodology. Attack is followed by counterattack, claim by counterclaim. Little thought is given to the toll this takes on the profession and ultimately society. When third-party payers assail us with evidence of the ineffectiveness of treatments, we counter with claims that the studies did not reflect practice as it actually occurs. Our argument is relevant and often appropriate, but it usually lacks power because we can provide little evidence for our contentions. That is one reason there is room within this journal for case reports and descriptive studies characterizing the nature of practice. In describing patients, we can at least provide examples of what we do. In the war for justification, this provides little comfort. But within the case report and other types of articles lies something more important, our secret weapon. A weapon so secret we often forget about it. The weapon is theory. And he goes on to talk about how therapists are usually immediately taste averse to the word theory, and I think we can skip over that section. Like my colleagues who look with disdain at some outcome studies of our practice, I've concluded that these studies do not always portray practice as it occurs. But then again, how can it? How can they? Not only do we lack descriptive studies and case reports, but we lack a body of theory, thoughtful ideas describing the underlying concepts that guide our practice. I think that sentence is so important, I'm going to repeat it. Not only do we lack descriptive studies and case reports, but we lack a body of theory, thoughtful ideas describing the underlying concepts that guide our practice. Where can researchers within and outside our profession look to understand the way we manage patients? Where are the descriptions of the concepts that guide our multifaceted patient management approaches? In the absence of conceptual models for the integration of treatments, the hallmark of what we often consider to be good physical therapy practice, we invite others to examine isolated bits and pieces of what we do. A good case report should include a justification of what was examined and what was done. There must be a thoughtful discussion discussion of underlying concepts and the hypothesized linkages among those concepts, and a thoughtful discussion of how those concepts were used to formulate evaluation and treatment strategies. Similar information should be in any report about practice, descriptive or experimental. When we talk openly about why we do things, we are talking about the word I promise not to use again. Ironically, these concepts that seem so esoteric are the bread and butter of good practice. They are our secret weapons in outcomes battles. When we generate concepts, we make meaningful research possible. When we try to do studies in the absence of well-developed concepts, we court disaster and fight isolated battles that can never lead to meaningful victories. Conceptual development of strategies used in the clinic can lead to an understanding of practice, to algorithmic approaches to problem solving that are discernible and therefore testable. In having dialogue about the nature and thoughts that underlie practice, we build consensus, a necessity in this era of practice guideline proliferation. If we believe in what we do, let's talk about the whys and wherefores. Yes, the theory. And then let's get on with the business of examining whether all of this works. I am not urging us to go back to the good old days when healthcare practitioners of all types justified their treatments not on data, but on the argument that the treatment made sense. Theory is the first and necessary step in the development of credible evidence-based practice. But theory alone is insufficient. In the past, we thought that to be credible, we had to have theories that used the latest physiologic data. This resulted in extrapolations that are now often embarrassing. Some of this behavior persists, particularly among those purveyors of new treatment strategies that have never been tested for effectiveness. Theory, however, can involve all levels within the framework of practice. We do not have to limit our conceptualization to cellular events. We can include concepts related to impairments, functional limitations, disability, and handicaps. These concepts are usually more easily elucidated than those of cellular events, and they certainly lead to readily testable hypotheses about practice and outcomes. Theory-based arguments will never win battles over the effectiveness of treatments, and this is how it should be. Even snake oil salesmen proffered theories, and theory is often the refuge of rascals who not only lack data, but run from data. We need well-developed theories that can be critically examined in the public arena. Theories that can give rise in a timely fashion to tests of hypotheses about the application of concepts. Our passionate belief in the usefulness of physical therapy is not transferable to our critics, nor will it prevent cost cutters from denying our patients care. But if we truly believe, let's use our secret weapon to initiate a credible re-examination of practice. Jules M. Rothstein, PT, PhD, Fellow of the American Physical Therapy Association, former editor-in-chief of Physical Therapy Journal, and that was written, believe it or not, in 1996. And I think, with the exception of some verbiage that's changed, this is using more disability frameworks as opposed to the ICF model, I think he's dead on, for the most part. And to me, this opens up some thoughts about a couple of concepts that I've hit upon previously and that I am passionate about thinking and discoursing about. The first one is the concept that the evidence-based triangle is actually more like an iceberg, and it's multidimensional. And I talked about that in Coffee with Kyle number, I can't remember which number, but I'll find it and link to it in the comments. And the other one is the concept of dialectic and discourse, which is that in order to have good theory, we actually have to have good disagreement. We actually have to put our ideas out in the public sphere. We have to be okay with people disagreeing with them, and we have to openly disagree with other people. And a quote that Jason Silvernail has used before that I'll summarize and probably butcher is that he essentially said in many very heated arguments or disagreements between physical therapists, especially in the outpatient setting, he would say, we likely agree on greater than 90%, but what we're arguing is the last 5 to 10, and that actually matters. But we need to remember that we are arguing on the last 5 to 10%. And I think there's a lot of things in here that still stand out to me that have either not changed or continue to be an issue. And one of them is that we need to put these theories in the public domain and let them be assessed, vetted, critiqued, validated, and even run down. And this is the not only the litmus test to a theory, but it's also kind of informal peer review, and I think that's really important. And this drifts into the world of philosophy, with which many researchers or scientists like to shy away from. but you can't do good science without some semblance of philosophy. And even by posing the question, you're starting to philosophize a little bit. And so I will leave you with a few questions, one of which, what is the philosophy of physical therapist? Or the physical therapy profession? And what is the role of physical therapy? I'm not sure I have any good answers, but let's at least start asking questions. It was good to see you. Have a great evening.